to come up. Dr. Balam is an ophthalmologist that is based in Durban, known to many of us here in the department and in Durban as our corneal specialist, really in the province as our corneal specialist. He completed his undergraduate degree at the University of Natal in 2002, and then followed on the diploma in ophthalmology in 2006, and then was awarded his fellowship in ophthalmology in 2009 and MA in 2011. He ran the corneal and cross-keratoconus clinics at Inkosi Albert Luthuli, as well as McCord's Hospital for a number of years, and we really do miss having him as part of our team. Dr. Balam is currently in private practice in the Durban area, where he continues his special interest in corneal disease. And this afternoon, he's going to take us through an approach to keratitis. Thank you, Shane.
Thank you very much, Nico. So today I'm going to discuss an approach to keratitis assessment, aimed a lot at the registrars, people who are learning at the moment. And my intention is to try and give you a scaffold upon which you can build your clinical experience with keratitis and help you think about it in a way that's useful. So my talk is very upside down in a way that it's structured in the way that you would see the patient in clinic rather than the way the textbook would be given. I'm not going to be discussing treatments, management, rehabilitation, and all of that, but just a focus on trying to get to the diagnosis. So firstly, you want to listen for clues in the history. Important ones are trauma, use of contact lenses, ocular medications, self-medications, and home remedies. For example, if the patients come from the clinic and they've already had their Coronex ointment, that's relevant. Ocular comorbidities or procedures. Duration of symptoms, that's duration from the beginning. When was the eye first red, first itchy, first painful? And then smoking. Smoking is important. It's important in those cases where you just can't seem to heal the ulcer. You have the patient in the ward for 2 months and you're really struggling, you have the diagnosis, but it's just not healing. Ask about the smoking. How many cigarettes they're smoking a day, it really does affect the cornea. And then, like every other disease, diabetes. And then you're looking for clues on examination, conjunctival inflammation and discharge, corneal epithelial defects, and you want to make sure you use your fluorescein. You're looking at the size of the defect and the shape. We'll discuss that. We'll discuss the corneal inflammatory infiltrates in terms of its size, its shape, and its position. Whether there's thinning or perforation of the cornea, that's important because you need to mitigate against any disaster. Presence of a hypopyon, you want to document the size, you want to know is blood stained, is it purulent. Eyelid abnormalities like keratitis and lagophthalma, and you want to check corneal sensation. And always examine the other eye. So your first question to ask is this a keratitis or not? Sounds obvious, but you'll be surprised. On your history, you're looking for the classical signs of inflammation, classical symptoms of inflammation. On examination, you're looking for characteristic features. If you look at the pointer showing up, no. So if you look at this case, very little inflammation. You've got this central opacity, but on history, you'll find out that the patient has a history of keratoconus, and that this was a sudden visual loss and sudden pain. And on examination, you see that there aren't any dense infiltrates, but rather a circular area of edema. And you know it's corneal hydrops, not a keratitis. Alternatively, you have a long history, years of slow deterioration in vision, foreign body sensation, maybe pain in the morning. An examination, you have this picture here, bilaterally, symmetrically, and you know it's a dystrophy. And look, no inflammation in the examination. So basic things that you have to keep in mind. You'll be surprised how often you might trip on that. Right. Also, you want to make sure it's not degeneration, keratopathies, ectasia, scarring, masses, and dystrophies. So in my experience, these are the high yield clues out of all of that you're looking for. Pain, duration, and it's duration from the beginning, contact lenses, steroid use, trauma or surgery, and what surgery was done. The position of the infiltrate, is it peripheral or central? And what's the morphology, that's the shape. Any associated ocular disease, and very importantly, the scrape for microbiology. Let's discuss each one of those more in depth. So you want to find out the pain and how they would rate it on a scale. How severe is this pain? You want to superimpose that description on the clinical picture that you can see. A bacterial infection is understandably painful. Fungal infection is understandably painful. But herpetic viral infection is less painful than it looks. They complain more of a drop in vision, foreign body sensation, red eye, and an examination there's decreased sensation. And neurotrophic keratitis on one end of the spectrum has little or no pain, whereas a Canthamoeba infection is more painful than it looks on examination. These Canthamoeba patients seem to be exaggerating. They're often depressed because of the pain, and they ask for surgery sooner. Doctor, can't you just cut it out? This is an exaggerated case, but perineural infiltrates in a Canthamoeba. And it can even look like a fungus with what seems to be satellite lesions with deep infiltrate. Sometimes there's an immune ring that can throw you off. And stromal vessel. Duration is another helpful symptom to ask about. Bacteria moves fast. So essentially, you want to take the duration of the history and superimpose it on the clinical condition again, the same way you do with the pain, and see what the relationship is. So bacteria moves fast, especially certain Pseudomonas, and the size of the ulcer correlates with duration in general. A 2 millimeter keratitis for 3 weeks is not bacterial, but an 8 millimeter keratitis for 5 days is more likely to be bacterial. Fungal, on the other hand, is slow. 6 millimeters in 3 days is usually not fungal. And viral, it depends on the type of viral keratitis. Contact lenses. In private practices, is possibly the most common keratitis you'll see. Pseudomonas is high on the list. Fungus is common. And other keratitis. You can get atypical infections, which is why it's important to do a scrape. You can even get sterile corneal infiltrates related to the contact lens that's not infective. Keep that in mind. And don't forget that even though they do wear a contact lens, doesn't mean that they can't have a keratitis that's unrelated to the contact lens, like herpes simplex, for example. And then a Canthamoeba. Keep that in mind, especially with the water issues that we have. Steroids. Very often, with steroids in combination with antibacterials post-operatively. So if you have an infection post-operative patients in steroids, you need to remember that fungus is a possibility. Herpes simplex epithelial keratitis, you know that instead of a dendrite, it tends to be more of a geographic ulcer in the context of steroid. I mentioned post-surgical patients. And then there's just those patients with allergies, for example, maybe prescribed steroids on their own, can also cause bacterial keratitis. In terms of trauma, you want to find out what the vegetable matter involved, fungus or bacteria. If there was soil, fungus, Canthamoeba, bacteria. If the patients had trauma in ICU, or just presence in ICU, often they're unconscious, they don't know if the eyes were traumatized, if the eyes were exposed. They can have a multitude of infections. The commoner ones, like Pseudomonas and staph, and then the more uncommon ones, like Acinetobacter, Serratia, fungal keratitis. Keep that in mind. Scrape is very important for microbiology. And sometimes the trauma is a red herring. It can precipitate hepatic keratitis. Can even precipitate a moral keratitis. Keep that in mind. Now you're looking at the position of the keratitis. The essential keratitis is usually bacterial, but the rules are often broken. Now, all these rules can be broken. The exceptions to everything I'm showing you here. But in general, you need an approach. For example, with the gonococcal conjunctivitis of the corneal melt, the ulcer often starts inferior. The position can be peripheral, in which case it's immune, usually, and can be viral, local immune, or systemic immune. And then look at the depth of the keratitis, right? Is it epithelial, stromal, where in the stroma, or is it endothelial? Fungus can be anywhere. And viral can also be anywhere, depending on which sort. Is it infected? Is it immune? Post-surgical, in terms of position, you must remember that when we operate, we're changing the anatomy of the cornea. If you're doing corneal surgery, you may create a plane, for example, if you're doing a dock or a LASIK. And now this plane is an artificial plane that you've created, and the contiguous spread of infection will not follow the same route as it will in cornea that's been untouched. So bear that in mind. Then there's the 100% complete keratitis, which is limbus to limbus. We have no idea where it started. In terms of hepatic keratitis and position, this is a nice classification out of the SAOJ. And epithelial keratitis, the superficial one, you know that again, right? The immune stromal keratitis, that's in the stroma. Necrotizing stromal keratitis, also in the stroma, tends to have an overlying defect. Endotheliitis, deep in the endothelium, looks like it's a full thickness keratitis because it has some overlying edema. And neurotrophic keratitis, superficial. There you have the, depending on what sort of keratitis, it can affect any depth in the cornea. Now looking at morphology. Here we have a round, well-demarcated bacterial ulcer, Pseudomonas. But generally, if it's not round, has satellite lesions or feathery edges, as you can see here, more likely to be fungal. Then there's the infiltrate that appears as an arc. Parallel to the limbus, like that, it would be immune. Locally immune or systemic immune. With viral, depending on the type, it can be an arc that's not parallel to the limbus, more like that. So, keratitis with an arc, you need to think a little broader. I spoke about depth of the keratitis. Then remember effect of treatment. Now, very often you'll have patients referred to with keratitis and they've already been on treatment. You need to know what effect that treatment has on the keratitis. For example, blunting of edges, rounding of the shape, the surrounding cornea may clear up on treatment, and it alters your impression of what is really going on. And then take a note of the vessels as well and what level they're. Look for associated conditions. So the pre-existing hepatic disease often recurs. Recent eye surgery or wounds, I've spoken about that. Blepharitis is very important. Please examine the lids and look for exposure of the cornea, look for lid scarring, and assess the tear film. And then look at your conjunctiva. The corneal scrape is very important. It's our gold standard for making an effective diagnosis. Do it before treatment is started. But not if it delays treatment in a fast progressing keratitis. If for whatever reason you don't have your plates, you don't have access to microbiology, and it's going to take half a day, you could lose that eye to Pseudomonas if you wait. Inoculate as many plates as possible and put some of the scrape onto a slide. The teaching is you want to debride off the slough, you want to scrape the base of the ulcer and the edge of the ulcer and put that onto the slide. Try and get bit of the cornea onto that slide, just so that there is a specimen for the microbiologist to examine. PCR is again very useful if it's available. You could swab the conjunctival sac, the corneal epithelium. You can do an AC tap depending on where your keratitis is. It's useful in bacterial, fungal, viral, and anemic keratitis. But the problem is the cough. Let's discuss the central keratitis. Here you have contact lens-related pseudomonas. They're both very different, but they're both contact lens-related pseudomonas keratitis. They've got a large ulcer with well-demarcated edges, and you can see the haziness of the surrounding cornea, the active inflammation and hypopia. On the other hand, you have this smallish white infiltrate with slightly irregular edges, and the surrounding cornea is not that involved. This patient's been on treatment. But the point being is that you cannot take one presentation of pseudomonas and expect all pseudomonas to look the same. Duration, we mentioned, plays an important role. This is a fungal keratitis that was there for 2 months. Dense, white infiltrates, it's got fluorescein on it, but there's a white infiltrate, slow growing. This is a bacterial keratitis that was there for 1 week. End-to-end complete keratitis. This is why duration is so important. Infiltrate looks the same. It's just duration that's helpful in this case. Central keratitis in herpes simplex, disciform keratitis, this is endotheliitis. You can see that this overlying edema, it's around and central. You don't have the dense white infiltrates in this case, and no epithelial edema. Neurotrophic keratitis, often central. Sensation is usually profoundly decreased, and there's ulceration. It's often chronic because it's been there for a very long time. And it can be mixed into other types of herpetic keratitis. It can also be superinfected. Is this a central or a peripheral keratitis? And this is where the whole thing gets a little bit nuanced. The way I would define a central keratitis is that the infiltrate behaves as if it doesn't know where the limbus is. So this I would call a central keratitis starting in the periphery. But if there was another lesion here, and another lesion here, and another lesion here, now it's behaving as if it doesn't know where the limbus is, and it's infiltrating parallel to the limbus, and I'd start thinking of a new keratitis. So you will see pseudomonas looking like this early if you catch it within a day. Keep that in mind. Now for the peripheral keratitis. That's your classic Murin's keratitis, but Murin's is a diagnosis of exclusion. So peripheral ulcerative keratitis, when there's an collagen vascular disease or autoimmune condition, it's usually due to that autoimmune condition. For example, SLE, rheumatoid arthritis. And the characteristic feature, whether it has the raised diverted edge, or whether it's 360 degrees, which it can be, characteristic is that it's an arc following the limbus. Yes, it can be superinfected and you may come back with a microbiology of bacteria. Doesn't mean it's not a Murin's ulcer. Just because it's precipitated by trauma doesn't mean it's not a Murin's ulcer. It can be precipitated by infection. It can even involve the entire cornea, eat up the whole stroma, leaving behind just a Descemet's membrane and vascularizing. So fungus can be present in the periphery. Superficial white infiltrate with satellite lesion. And can even present as if it's following the arc of the limbus, dense white infiltrate, full thickness, satellite lesions, fungal keratitis. This is the arc that I was describing in herpetic keratitis. with infiltrates in the stroma, no overlying epithelial defect, deep stromal vessels. This can be behind a lipid keratopathy electrochronically. And this is your immune stromal keratitis. Examine the iris looking for blepharitis because marginal keratitis is very common. Can present with white infiltrates following the arc of the nimbus, epithelial defects or not. Can present as a flicked in a single lesion with a blood vessel. This is an immune, the primary pathology here is an immune reaction. And it's an immune reaction to staphylococcal antigens on the iris. But this would be part of your differential in peripheral ulcerative keratitis. Now we're looking at the depth of the cornea. Epithelial lesions. A 3-day history of irritable red eye. What's the diagnosis? Corneal scarring. So you put a drop of fluorescein, and then the answer is there for you. All right. You all know this is the keratitis. In these lesions, you'll be able to isolate the virus on the PCR. The active viral infection, a few drops of steroid, and you have geographic ulcer. Adenoviral keratitis, you look for clues in the conjunctiva of the follicular conjunctivitis. Often it will occur in epidemics. Patient presents with decreased visual acuity, superficial punctate keratopathy, and these white lesions on Bowman's membrane that eventually disappear. Parkinson's keratitis. Patients often present with a long history of foreign body sensation, pain, decreased visual acuity. They often come in with diagnosis of dry eye, and they often do have a dry eye. They just don't respond to treatment. When you have that sort of we don't know what the cause is. Some people feel that it's a viral cause. One of the clues is to lift the upper lid and look for the lesions. If you have lesions under the upper lid involving the entire cornea, it's something to consider. Another epithelial disease. Stromal keratitis. I discussed immune stromal keratitis. Here you can see the deep blood vessels with the advancing infiltrates. There's inflammation. It's chronic and recurrent, neovascularization, and you can get lipid keratopathy. Looks like crystals in the cornea. And you have to watch for perforations untreated. Necrotizing stromal keratitis. Also a viral condition. There are dense, deep corneal infiltrates and necrosis of the stroma. And there's surface ulceration, not because it's an epithelial disease, but because epithelium has nothing to anchor down to, so it just sloughs off. Microbial cultures are usually negative, but they can be secondary infection, bacteria, fungi, commensals, and they can come up on your microbiology and throw you off. Sometimes you treat those infections, the keratitis is still not healing. There's a lack of response to the antibiotic. But there are often a history of previous episodes of corneal inflammation. Here's a nice picture of early stromal vessels. Why do I say early? Any keratitis can give you stromal vessels if it's there for long enough. But in hepatic keratitis, 2 weeks and you've got these early stromal vessels. Look at the level. It's deep in the stroma. You can see the overlying normal stroma above it. Whitish infiltrates at the end of the blood vessels. And look here, those blood vessels are not contiguous with the conjunctiva. They're not conjunctival, but they're entering deep in the cornea. So that's your early deep stromal vessel in hepatic keratitis. That would be immune stromal keratitis. No overlying defect. What about the endothelium? Endotheliitis is usually focal or sexual, but can be disciform and can even be diffuse. And if it's severe, it can clinically look like bullous keratopathy and can be mixed with other types of hepatic disease. Disciform keratitis, I've showed you this before. So in summary, these are the etiologies you're trying to keep in mind. But the patient presents to you with infiltrates in the cornea. So what's your plan? You want to classify the keratitis as best you can in terms of position, size, shape, depth, the margin, the time period, whether it's ulcerative or non-ulcerative. You can describe all of that. Decide if it's infective and what's the reason that you're saying it's infective. Decide if it's purely inflammatory. Have a differential diagnosis based on your history examination and think broadly and don't stop thinking. You need to decide what's your most likely etiology of pathogen and treat for this and make sure, but remember your assessment is ongoing and you await confirmation from your screen. Bear in mind it can be mixed or single etiology. And you may only know the diagnosis after your trial of treatment. But you can only do a trial treatment if you're not using polypharmacy. If you've got an antibacterial and an antifungal and an antiviral and a steroid and the patient gets better, you have no idea what keratitis you've got. In conclusion, the diagnosis is often clinical. There are certain rules, but they are sometimes broken. Understand that the cornea has depth. Take your specimens early and work with a single clinical diagnosis based on your educated assessment. Change direction based on new information or failure of treatment. And don't forget immune keratitis. The one cause of irreversible blindness in keratitis is secondary glaucoma. So please learn to check your intraocular pressure of the patient. Thank you.
Thank you, Dr. Balan, for that. Is there anybody that has any questions?
Put one question in the chat regarding drug holidays. So you mentioned do the scrapings prior to initiation of therapy. Sometimes we get referrals at tertiary institutes when patients have failed therapy for culture. So sometimes the referring doctor will give the patient a drug holiday for 48 hours, let's say, stopping, fortified antibiotics. Do you think the drug holiday is helpful in the referrals? And my second question was regarding AC taps. You mentioned that when do you do that in the setting of infectious keratitis? Is it mostly when you're concerned about herpes, or are there any other cases where it's useful?
Thanks for that question. To deal with the AC tap, it's usually in cases of endotheliitis, and we're trying to determine whether it's herpes simplex, cytomegalovirus, or some other virus that we're not thinking of, or whether it's just not effective and we're misinterpreting the pathology. And then in terms of the drug holiday, yes, it can be very helpful. The difficulty is in those cases, when I mentioned skipping the scrape, it's in those cases where I'm worried about losing the eye. I'm worried about perforation because the history is so short and keratitis is so deep and there's a imminent perforation. And that's where I would avoid the scrape. But in most cases, you will do a scrape. Another benefit I found of the drug holiday is that sometimes you stop all the medication and you find that 48 hours later that keratitis is better, and gives you a clue that to the fact the possibility that the medication itself could be toxic to the
Thank you, Dr. Balan. I don't think there are any more questions on the floor. So in the interest of time, we're going to move on. So our next speaker is we're very happy to have Dr. Chokozam Zanela here, who is an esteemed pathologist in microbiology, and she's based at the Nelson Mandela University Medical School, which is in previously known as PV, in the Eastern Cape, and currently Her role is a lecturer and module lead for integrated pathology and microbiology. Her qualifications include MBCHD, MBA, FCPath Micro, and MMed Micro. And she's recognized for her expertise in pathology and her pivotal role in healthcare. But beyond this work in pathology, she's globally recognized as a health icon for mental health awareness and wellness. And her philanthropic efforts focus on improving access for underserved communities and promoting initiatives for infectious diseases and mental health. So join me in welcoming Dr. Msenela.
So UKZN, greetings everyone. So I'm thrilled to be speaking with you all today. I am a girl, but today I'm representing Keratitis. And as has been mentioned, I am in the medical school and is spearheading pathology curriculum and carrying on the legacy of the late Prof. So my talk for today is a lab liaison. So I'll be covering the critical role of the diagnosis and keratitis management, but I'll be focusing mainly on tissue sampling, media, and antibiotic stewardship, which some of the things that already been mentioned. But in my talk, we essentially cover the importance of accurate diagnosis in a micro lab, sample collection and handling, what is contained in an IPAC, what diagnostic methods we have in micro, the challenges we uncover, how to overcome them, and then as I end, I will conclude with antimicrobiological approach. So why it's important that in the laboratory we give an accurate diagnosis or accurate results is for us to be able to help you optimize patient care and to reduce inappropriate use of antimicrobials. As we all know, we have an issue of massive antimicrobial resistance, so we do try to control the antibiotics. So in a laboratory setting, how we ensure that we're giving you a quality result, we oversee the whole testing process. So it starts at bedside, at flow site, at collection. They call that the pre-analytical phase. In analytical, it's us when you send us the sample, we process the sample, we give you a result, and post-analytical is when now you're actually getting the result. So according to research, factors that affect the quality of the result, most of the errors, they occur at bedside. So it's about 46 to 60%. So why we're having lesser errors is because we have more stringent quality control processes. So before the results come out, there's so many people that have to ensure that everything was done as it's supposed to be. And post-analytical, we have a bit of control there as well, because we also are available to help to interpret the results. So if you get a result and you're sure how to interpret it, and you suspect a transcription error, you can call a technologist and microbiologist to help you interpret the results. So which is why today I'm zooming more into pre-analytical. That's where most issues happen. And it's in the little things, and I know because I've been a clinician myself, it's just easier to focus on collecting the actual sample and overlook the requisition form, which is what I do for my students in the first time, just to complete the requisition form, make sure you actually have corrected the right test that you're looking for. You have labeled the tube. You'll be amazed how people don't label the tubes, then you're not certain that it is for the patient and the date, and sometimes transport errors, we see that quite a lot as well. So just focusing on keratitis. So what is important for keratitis to make sure you get a quality result is the sample type and the amount, is a technique, how you collected it. The handling and transport is important. And if in doubt, I always say call a friend, whether your friends are microbiologists. So the current flex is to have a microbiologist on speed dial. So if anything, just call us. And I wanted to share a recent incident that was on call over the weekend. Our esteemed colleague had one patient with CRE and wanted to screen all the patients. Well, about 20 patients that he wanted to screen. Forgot to call the microbiologist, sent us 20 nasopharyngeal swabs, which I had to reject, unfortunately. And I told them, unfortunately, what you're looking for doesn't stay in the nose, it stays in the guts, so there was nothing I could do. So if you are calling us, it could save you trouble, because now you won't sometimes have had to repeat a sample, the patient is not there. There's so many issues that get involved. So if in doubt, please always call us for assistance. So with sample type, the most common sample that we usually recommend, as already been mentioned, is a scraping. From where we usually pick up your bacteria and the viral pathogens. The corneal biopsy, because it's more invasive, we recommend it for more complex cases. So like if the corneal scrapings are not able to give you an organism, if there's poor response of antibiotics or the organism has infiltrated deep into the corneal stroma. So the virologist, when I asked them, they said they prefer the vitreous fluid. Some places they do see samples of which locally we don't do that. But in our local setting, if you want to diagnose viruses, we recommend the vitreous fluid. So how you collect an appropriate corneal scraping? Yes, it should be before a patient takes antimicrobials. You must use a septic technique, and the amount should be adequate for you to put on a microscopic slide. And the culture plate, I'll take you through the culture plates that we recommend. But if you feel you won't have enough amounts of the spray paint, please prioritize culture because that's our gold standard. So it's more sensitive than your microscopy. So the microscopy is ready because it can give you a quicker result. But if you want a more sensitive, cultures are preferred. So if you don't have enough, you rather, but we have to look at things and not give us the microscopy slide. So when you're collecting from the advancing end of the ulcer, you spread multiple areas of ulceration situation. You must use a sterile spatula or sterile needle, using short sprint in direction. And if suspecting fungal ammonia, we always recommend that you send us a corneal biopsy. So usually an IPAC can differ from sites, but I'm just showing from what we recommend from EC. So we usually put solid agar, a microscopic slide and a microscopic slide holder, and you put it in there. So how you inoculate, once we recommend about 3 to 5 scrapings per cornea. So the order, you start with microscopy, you write the name, list of birth, hospital number of the patient, using a grease pencil and then make a second on the slide, and you inoculate in the set because that's where we do the brainstem. So with the media, then you follow with your solid media, then you put media. So when you inoculate in the media, it helps us identify those organisms better if we use that seed formation as demonstrated. And before you inoculate, please make sure that you check for expiry dates and check if those plates are not contaminated because it may overgrow what you are looking for. And once you've collected, you read and you use a selective around the perimeter. You must have it transported to the lab immediately. And if delayed, you must keep the room temperature, do not refrigerate. It affects the quality of the sample. So the blood acres on our side, we try and control it because of availability. And as long as you have collected accepted enough, we should be able, because we need that one colony to be able to identify an organism. We are now a bit more advanced than before, so we don't need big samples now to be able to find organisms. I know that taking more, though, it gives you more, which is true, depending on material load. But often, because we are recommending the culture media, which is more sensitive, we are able to help you identify organisms. So we for solid media, we usually put in our packs your black agar, your chocolate agar, the salivary across agar with chlorophyll. So black agar is just your general purpose media. It isolates the most common, almost common organisms there, your streps, and the common gram-negative organism, the pseudos. We are able to grow them in black agar. The chocolate agar, the added value is just that it allows fastidious organisms to grow. So it's those organisms that need more nutrients. So it is just the black liquor that is banned and provides more nutrients. So you're able to grow that organism like the Neisseria gonorrhea and Haemophilus influenzae. So the SARA period is for fungal infections. So the ectopic chemical, what it does, it will inhibit the bacteria and allowing the fungal pathogens to grow. Then the liquid media, really it helps with those patients that have already been exposed to antibiotics. So it can dilute the concentration of the drug, then increasing the sensitivity of microorganism, and you are likely to reduce the false negatives of the results. So I do recommend that being hard infusion, as it will help, especially because the eye samples are small to be able to detect the pathogen. So when it comes to the corneal diagnosis technique, so once you've collected the tissue, you should put it in a container. So when you're sending to microbiology, you cannot put formalin. Formalin is recommended for 2 years, but we do advise that if you send the tissue to microbiology, it can help you maximize the diagnostic yield. So we want to receive the sample in the lab. We group our samples into sterile and non-sterile sites. The non-sterile are those samples where you grow, samples from sites with normal flora. So we consider the cornea is sterile, meaning we don't expect any organism. So any organism that we're growing becomes significant. So to mitigate errors and simplify the flow, we put the corneas with our sterile specimen. So when we're getting the specimen now, remember the sense of the slide, we will first do a gram stain, so we're able to see bacteria. But on the form, if you're suspecting fungi, please request fungi microscopy. If you can't remember these terms, but there are 2 microscopic techniques that we use. We got the KOH, and we got the lactophenol cotton blue, and that will also help us detect the acanthamoeba. But you can just document and say you are looking for fungi microscopy, we know what to do. And then following that, we do culture sensitivity from that phase. But with fungal cultures, it takes longer to grow, about 3 weeks, and for the bacteria about 3 days, as I mentioned, it is lower, all standard. Molecular tests, we recommend them often for viruses because of the invitation between public and private is more readily available. But the upside of the molecular test is got high sensitivity and specificity, and you get your results in the program. So when it comes to keratitis, challenges that we face is that the sample volume is limited, and as I said, it's very important that we find limit errors because some of the samples are limited, are repeatable, and because this thing is not as bedside inoculation, looks great, but we do encounter contamination as well, and depending on the person who's doing it, it might affect the quality of the results, but also it limits the range of the test we can perform. And also, if patients have been on antibiotics, it becomes a challenge because there is reduced bacterial load, so we're not able to detect the pathogen. And also for those remote sites, sometimes the sample becomes negative if there is a delay in transport, but some of the organisms they die as oxygen. And also, because some laboratories of ours, there are no pathologies, it's the technologies that are processing. So they are actually more stricter when it comes to rejecting samples. So we feel there's that gap of them being trained on the anatomy and pathophysiology when it comes to the eye. We feel it's a gap that we have identified and we are working on. So just be wary that at times they may not see a need to communicate if we identify errors. So if you feel the sample that is really critical, you please form the laboratory and inform them and say the sample is critical. Please make sure it is done because they don't know the importance and significance. They will just say mistake, it's not in our standard or SOP, so we reject it immediately. Just as a proposal for my side, how we can mitigate challenges in the lab is for us to collaborate with Antiday, just to have a more close relationship to optimize, so we can be able to know the challenges and help improve the system. Like what Dr. Mati has introduced today with marine life is related to education. So as microbiologists, you can explain if they come up with routines, how to collect samples, the importance of labeling, which is already at place. And also to have like a system in place to restore IPACs. Like I said, it's very important to be sending us sample from expired media, different papers and contaminated media. So we nice in the system that actually tell you checks on your IPACs if they're still in good condition. And in EC, what we have in place with our ophthalmology, we have our regular courses that go and take samples, so the nice thing to put. We have a course series of courses that ensure that specimen gets to the lab much quicker. And I think it will be great if there is some consultative services between that are parts of the academic setting to advise them on that diagnostic test. So, and now as I land, I will conclude with antimicrobial stewardship. So it is a global issue and ocular pathogens are not sections. So even with eye infections, we still have to prescribe if it's inappropriate. We must adhere to the local guidelines antimicrobial prescribing. And if this script is required, you have to write it if it's clinically indicated. So to make it easy for people to remember, the 4 Ps of optimal antimicrobial therapy is to give the right drug, is to give the right dose, is to de-escalate once they're giving the pathogen. I always encounter that the people, they are always very fear giving a narrower spectrum antibiotic, but from our experience, it works, it helps to reduce the antibiotic. We have limited options and also keep for the right duration of treatment. As I said, with eye infections, it's a bit of a challenge because we have limited options because of the unique routes of administration. And studies are already showing increasing resistance to the fluoroids and amino acids. So it is really crucial that we keep antibiotics intimately included. So to have an effective antimicrobial stewardship program in ophthalmology, I only chose 5 steps, which I think it's a bit easier to implement if you don't have anything in case. It will help to have a regular reporting of information on antibiotic use and resistance to clinician, pharmacists, and hospital industry. So I did check around for feedback on what was out there, but I did see a nice article in principle where they were looking at the common mechanism and susceptibilities, which kind of helped at that point. It was most of the drugs that we're using is susceptible, which is aligned with the program as well. So they're nice to always keep up and know where you are sitting in terms of resistance and antibiotic use. And then secondly is to collaborate now with the microbiologists in the laboratories to understand the current susceptibility and resistant patterns. So we are able, if you ask us, we are able to extract data for you and analyze it for you and be able to guide you and study where you're sitting and advise and recommend. And we also sit like in those PTC committees and we help develop the guidelines and protocols for management of the infections. So what also is of value is to educate the clinicians, your pharmacists, nurses, hospital leaders, and not forgetting communities. Because these days people are educated, I call them self-treatment enthusiasts. Very easy to just go to pharmacists and ask for an antibacterial eye drop. So it will help make communities aware of the value of being diagnosed by a clinician and the antibiotic being recommended by clinicians. So we are able to control the use of antibiotic. And lastly, once you have put antimicrobial stewardship system in place, it is important that you monitor, you evaluate if people are implementing the guideline, and if the implementation is making an impact, is making an impact, and to prevent antimicrobial resistance. So my take-home message with regards to antimicrobial stewardship, play your part and control the overuse and misuse of antibiotics as much as you can. So as I conclude my chat, I just got some microbiology knowledge for my students. So I realized that my students don't like my subject, it's a little bit boring. So we try and have some bit of fun because they like the sorts of videos. So they make videos to help them remember concepts. So I asked them to do this one specifically for you to just showcase their skills. Okay, good. Okay. So you want the odds, but yeah, thank you so much. I also wanted to acknowledge the Secretary Abrahams from AMPAS who has it for people in private, it's a really nice comprehensive sheet for ophthalmology sample. And then I just wanted to share this in honor of Professor Legacy. That's my very first class. It was our very first day of lecture last year, and I baked a cake for them. So yeah, we didn't know how our life was going to turn out like, but yeah, we had a specific class rates. And this is my current class, the ones that did the video for today. So thank you so much.
Thank you. I think there are a few questions from the Zoom meeting. So do you want to have a look? The one says, a question regarding, the current South African guidelines suggest the use of monotherapy with fluoroquinolones, and many of our departments are using fortified antibiotics for empiric therapy. So is there any evidence to substantiate this practice, which contradicts the guidelines, or should we still follow the guidelines?
I think the best assistance and special will be for a pharmacologist. From my side, I would say just follow the guideline and if you are certain, you can consult with the pharmacist to give you the best advice.
That's the only question online. Is there anybody else, or especially in the room? No. Let me go on.
Thank you. It is my absolute joy and such a privilege to be able to introduce Professor Haseka Wareta. She is currently an associate professor in the Department of Ophthalmology and the Eugene Duquan Professor of Ophthalmic Education at the Johns Hopkins University School of Medicine. She received her MD degree from Johns Hopkins University and the MPH degree from Johns Hopkins Bloomberg School of Public Health. She completed her internship in internal medicine at Johns Hopkins Hospital, followed by an ophthalmology residency at the Wilmer Eye Institute and a corneal fellow at Bascom Palmer Eye Institute. Dr. Wareta serves as the ophthalmology residency director and director of the Eye Trauma Center at the Wilmer Eye Institute. Her national leadership roles include being chair of the National Medical Association Ophthalmology Section, immediate past president of the American Society of Ophthalmic Trauma, and president-elect of the Maryland Society of Eye Physicians and Surgeons. She has multiple publications in education, in cornea, cataract, medical education, quality improvement, and diversity, equity, and inclusion. Thank you very much for joining us this afternoon. It really is an honor to have you. Over to you, Prof.
Thank you so much for the kind introduction. It's an honor to be here. So although I came to the US when I was a year old as a baby, I was born in Ethiopia. So I've always had an interest in international ophthalmology. So really appreciate the chance to present and collaborate and learn. So I will be presenting cases of an atypical keratitis that I've encountered over my last 10 years practicing as a cornea specialist in the US. I have no financial disclosures, and I will be doing a case style based presentation to highlight some of the points our other what wonderful speakers have made in terms of the importance of paying attention to the history, clinical examination, and the need for microbiology and tissue diagnosis in our treatment. Because of the time limitations, I won't go into an in-depth overview of the treatment, but I'll just briefly touch on evidence-based treatment strategies, which will be our final talk. So the first case was a patient I saw who presented with 4 days of right eye pain and blurry vision. She was a contact lens wearer, and then although she had excellent hygiene, she notes that she had started used a new contact lens solution that she had bought a few days prior to presentation, and she had been wearing contacts for over 40 years. So this is what the patient looked like on presentation. The visual acuity was 6/15, pinholing to 6/9. And you can see there's an infiltrate that's about 2 millimeters in size. It had a dendritiform appearance, and there was a mild anterior chamber reaction. So she was cultured immediately, and the acanthamoeba was negative. She was started on topical moxifloxacin every hour, and she was also started on oral valacyclovir, and she continued to improve slightly, and then she was started on steroids every 2 hours for the haze. And you can see what she looks like on follow-up. So the infiltrate is deeper, there's satellite lesions. We did perform confocal microscopy, which was inconclusive, and finally a biopsy was performed. So in addition to the importance of microbiology, pathology is also important. So you can see here what her pathology showed. So it showed numerous septate fungal forms, even though the microbiology was negative. So this patient had a fungal keratitis related to contact lens wear. And you can see that the contact lens use as a risk for fungal keratitis has increased. And in this study that was published from Florida, it surpassed trauma as the most common risk factor. So about 20 years ago, just short of 20 years ago, there was an outbreak associated with contact lens solution. It was a Bausch & Lomb solution called Renew with Moisture Lock. And this outbreak was reported in North America, Asia, as well as in the Caribbean. And you can see that there was a fusarium related outbreak, and 30% of the cases reported required corneal transplantation. So a pretty significant outbreak that happened. So it's, again, important to think about factors in the history, and in this case, doing the epidemiology to trace it back to this solution, which was recalled off the market subsequently. So back to our patient. So our patient was treated with topical nitomycin. She also received oral voriconazole treatment for a period of a month. And I also did intrastromal voriconazole injections because the infiltrate was quite deep. And she did require repeat injections. I injected over a period of several weeks, 1 to 2 times a week. And you can see eventually the ulcer did regress, and her current vision, she corrects to 6/6, and it's been years now and is still doing well. So a brief slide on the treatment of fungal keratitis. So the main study to know is the mycotic ulcer treatment trial. That was a multi-center trial, including Aravind Eye Hospital in India. So what this trial showed was natamycin is preferable for the treatment of filamentous fungi, such as in our patient. And then I mentioned we did treat our patient with oral voriconazole. So we have to be very careful with oral voriconazole, as there's many side effects, in the main one being liver toxicity. And you can see that the MUT2 trial showed that the voriconazole was not there appeared to be no benefit when adding that. So sometimes we do still use it, but you have to be very careful. And I check liver function tests every week. At our institute, we actually had a patient who was on a statin for cholesterol, who was started on oral voriconazole and had liver failure and subsequently died. So it's something not to take lightly. My second case is a patient who presented with a 54-year-old who presented with left eye pain and blurry vision for 2 weeks. This patient was also a soft contact lens wearer. And on exam, there was the description of a dendrite, corneal edema, and an AC reaction. So the patient was treated with Valtrex in addition to moxifloxacin, as well as a steroid. So this is what the patient looked like about a month after the initial presentation. And the patient was not getting better with the treatment of the oral antiviral. So a corneal culture was performed, including acanthamoeba, and the E. coli overlay plates came back positive for acanthamoeba. So you can see there was a significant delay from when the patient presented with the symptoms and was ultimately diagnosed with acanthamoeba, which is all too common, the story. So I spent some time in Moorfields after my fellowship at Bascom Palmer, and one thing I learned there was in a soft contact lens wearer, if you're going to diagnose herpes, you have to have done a culture for acanthamoeba. And again, this is a typical story of being treated for a viral keratitis when all along it was acanthamoeba. So this patient, unfortunately, did not do well because of the delay in the diagnosis. As a last-ditch attempt, corneal cross-linking was performed, which has been reported to be a treatment in refractory acanthamoeba, but basically ended up losing the vision associated with that delay in treatment. So as we know that acanthamoeba is a severe sight-threatening infection, and it can result in vision loss in 1/3 of patients. The primary risk factor is contact lens wear, in particular swimming in contacts or any kind of well water exposure. Early diagnosis is key, but unfortunately, even today, there's too many delays in the diagnosis of this vision-threatening disease because it's a great masquerader. As our first presenter noted, it can really present with any appearance. So there's sort of the classic appearance of the ring infiltrate, which is a late finding, but it really can present looking like fungal keratitis or herpetic. So again, my lesson from Moorfields is do not diagnose herpes in a contact lens wearer without ruling out acanthamoeba. And this is a study that we published a few years ago showing that there's, again, a significant delay in the diagnosis of acanthamoeba keratitis when we receive these referrals. And you can see the mean time from symptom onset to referral is 53 days. And about 40% of patients are misdiagnosed with herpes prior to presentation. So the management we know involves topical therapy with usually PHMB or chlorhexidine. There are other oral treatments like miltavocine and also in refractory cases, cross-linking. But again, early diagnosis is associated with good outcomes, and so that's the key to good vision after having an acanthamoeba infection. My next patient was a 33-year-old male who had a history of LASIK many years ago and was referred for refractory keratouveitis in the left eye. Previously, they were diagnosed and treated empirically for zoster keratouveitis, although they had no classic history. So they were started on chronic valacyclovir, steroids. They had some issues with steroid responses and required management of glaucoma. So this is what the infiltrate look like. So you can see the stromal infiltrate. There's no epithelial staining, and the corneal biopsy at the outside institute showed no organisms. And you can see here the patient, despite treatment, did not get better. So eventually the outside institute did a therapeutic corneal transplant, and you can see here what the corneal transplant button looks like on pathology. So if you look close, you can see organisms in the stroma here, which revealed this is a Mason trichrome stain, and you can see that the diagnosis was microsporidia. So this is an organism that was initially classified as a protozoum and now is reclassified as a fungi. And it can occur in immunocompromised, so that's where it was sort of first described. But it can also present as a stromal keratitis in immunocompetent patients. And our patient had a classic history of a slowly progressive course. You can see the mean duration of symptoms is nearly a year, 332 days. It can also mimic other infections like viral and fungal. And again, like in acanthamoeba, the diagnosis is often delayed, and it's hard to culture, hard to treat. So risk factors for this include prior refractive surgery, trauma, and contaminated water. And so it's again notoriously fastidious, so difficult to culture, and so it should be considered in any case of prolonged stromal keratitis, which is culture negative, not responding to conventional therapy. And you could see even the biopsy was negative in this case, and ultimately it was the transplant that revealed the diagnosis. And the diagnosis can be with stains, as I showed, and transmission electron microscopy and fluorescent techniques can also be used. And again, it's difficult to treat, but you can see that topical fluoroquinolones and is usually what we treat with, and sometimes it does require surgical intervention, such as in our patient. The next patient is a 73-year-old one-eyed patient who presents with infectious keratitis of the right eye. The patient initially presented to our emergency department, and unfortunately, the left eye was lost due to advanced glaucoma. The right eye, you can see, had a complex ocular history, including glaucoma surgery, and the patient had a history of recurrent epithelial defects in the setting of corneal edema resulting from the glaucoma surgery, so was managed chronically with a bandaged contact lens in that eye. And so when the patient came to see us, they were being treated with, again, this is a theme here, oral valcyclovir, as well as topical steroids for a presumed herpetic stromal keratitis. So this is what the patient looked like when I met him. And you can see here that there's a hypopyon, there's a patchy stromal infiltrate. So initially we cultured immediately and started the patient on fortified antibiotics. So the culture came back within a few days, and the diagnosis was this rare bacteria called Achromobacter xyloxidans. And it is notorious for being multi-drug resistant. So it was resistant to tobramycin, gentamicin, and you can see what it was susceptible to here. So we treated the patient, and unfortunately, medical treatment did not eradicate the infection. The infiltrate was too deep, as you can see here. So despite months of treatment with topical antibiotics that the Achromobacter was sensitive to, the patient had recurrence of the hypopyon. So eventually I did have to transplant this patient. So I transplanted the patient, debrided I took out all the areas of the infiltrate, and you can see the patient actually did quite well postoperatively. The corneal button did show the organism was persistent, and the patient, who I followed now years later, has 6/12 vision in his only eye. So this is a rare cause of bacterial keratitis, and the history of our patient is sort of classic. It doesn't happen in normal eyes, but there's usually some underlying topical corticosteroid use, previous corneal transplant, or contact lens wear associated with it. It's less virulent than Pseudomonas, so the course is not as fulminant as we saw with the classic bacterial keratitis, but it's a gram-negative waterborne organism. And again, it's usually patients with ocular surface compromise. And the key is it's often multi-drug resistant, so to our traditional quinolones. And so early diagnosis, again, with the culture may avoid the need for therapeutic PKP, as our patient had to have. And my final patient is a 71-year-old female presenting with a 6-week history of foreign body sensation, light sensitivity, and redness. The patient had a history of dry eyes, cataract surgery 4 months prior to presentation. So this is what the patient's infiltrate looks like at presentation. So you can see the vision was 6/9, so it was still good, but you can see it's this lesion here with associated injection. And so corneal culture and biopsy were performed, and the patient was started on fortified topical antibiotics. So this were the biopsy results. So you can see that Zeal-Nielsen stain showed gram-positive cocci and acid-fast organisms. So and the culture was positive for Mycobacterium chelonae. So Mycobacterium chelonae has been associated with soft contact lens wearers. So this is a case report that was published 20 years ago, where it was associated with soft contact lens wear. It's not commonly found in the setting of soft contact lens wear, but again, the microbiology here was key to make the diagnosis. Most commonly, we see it in the setting of refractive ulcers after refractive surgeries, where we're used to thinking about mycobacterium. But again, the microbiology was critical to make the diagnosis. And so the treatment for Mycobacterium keratitis is topical aminoglycosides such as amikacin. And again, we do see these after refractive surgery. And so when you're after refractive surgery ulcers, you always have to think about this organism and make the diagnosis early. So in summary, atypical corneal infections are often more difficult to treat because number one, they can be organisms that are resistant or like in the case of acanthamoeba, have a cyst form, and they can be deep stromal infiltrates, which are again difficult to treat with topical medicines. There's also significant delays associated with the diagnosis of these atypical infections, which make them more likely to result in poor outcomes and sometimes require surgical intervention. So early diagnosis and a high index of suspicion when it's not responding typically is absolutely necessary. So I'd like to again thank you for the opportunity to be here, and thank you for for my colleagues who are involved in taking care of these patients, as well as our pathologist at Wilmer, Dr. Eberhardt.
Thank you, Prof. Ureta, for sharing all your interesting cases with us. So there is one question from the floor, which is there a difference in effect between acyclovir and valacyclovir? Or is the choice of drug based on the frequency of dosing?
Yep, exactly. No difference. So they're equally effective. And yes, the acyclovir is 5 times a day versus the valacyclovir, which is 3 times a day. The valacyclovir is also significantly more expensive. So here it really depends on the patient's insurance and what they will cover, but you can use either just as effectively.
Okay, thank you for that. Are there any other questions that we have? So we'll move on to our next speaker, if that's okay. So I just want to introduce our next speaker, which is Professor Swati Tomar, who did her MBBS and MS in ophthalmology from the JN Medical College in Aligarh, India. And she did a fellowship in cornea and anterior segment services from the L.V. Prasad Eye Institute in Hyderabad, and joined as adjunct faculty at the L.V. Prasad Eye Institute. So currently she is the honorary director at the Swanetra Eye Hospital in Jaipur, in India, and a professor in unit head in cornea in the Department of Ophthalmology at the NIMS Medical College in Jaipur. She was the honorary medical director at the Eye Bank Society of Rajasthan in Jaipur in India for the last 15 years, and this is a unique community eye bank. She's also the first woman corneal surgeon in the state of Rajasthan in India to have done maximum corneal surgeries for eliminating reversible corneal blindness, and is involved in various government projects to eliminate blindness. She received the Young Achiever Award in 2017 for excellent work in the field of medicine and in helping to eliminate corneal blindness in India, and also at the Health Excellence Awards in 2019. She's also a member of the Corneal Surgeons Task Force of Sight Life in the USA, and she's a founding member and regional lead for Southeast Asia and the Joint Secretary of the Women Ophthalmologists Worldwide and a member of the State Blindness Control Society. So we are very honored to have her speak at this meeting today. Thank you, Dr. Jonia, for your talk.
Thank you so much. And thank you, Dr. Mathe, for giving me a chance to speak and be here. I am going to talk. Most of my speakers have already taken the topic so vast and so vividly and so well managed cases. I'm going to take you through the management of microbial keratitis, which we usually see that Is my slide moving? Yeah. So we all know and we have seen these cases that were presented earlier by my previous speakers, that how sight-threatening condition and an ocular emergency is when we see a microbial keratitis patients. And we also know that there's a lot of evidence that's already in place for intensive topical antimicrobials, antifungals, antivirals, which are there and which are considered gold standard of treatment of microbial keratitis. But in spite of appropriate diagnosis that we do, which our very esteemed microbiologist, she said that how much importance we should give to the microbiological workup. In spite of that, there are a lot of times we see that there's a significant morbidity that it brings because of the widening of the ulcer edges, and also sometimes it leads to corneal perforation and scarring later in the end. When we go through this, that why is it happening and what are the organisms which are involved, we come to a conclusion that since India is a tropical country and so is Africa, we understand that in summers and in monsoon we see a variety of fungal infections or parasitic infections which are much more commoner as we would see any bacterial infection. The bacterial infections almost remain the same. It is the fungal and the parasitic infections which take a forward course, because most of these patients, like in the first slide, there's a Pseudomonas here, there's an Aspergillus in the second one, and the third is a acanthamoeba infection. So we can see that when we have a typical presentation like this, then it is easy to diagnose. But when we do have atypical presentations, like Dr. Fasika said, that it can present in many ways and in many forms, it becomes difficult. And so we should give a little importance to what is the history and what is the reason behind getting an infection. We all know the microbiology has an undeniable role in isolating the bacteria and the fungal species, and the treatment protocol has remained unchanged since then, since the time and again these bacterial and fungal infections in varying forms, whether they're gram-negative or gram-positive, and it aids to our diagnosis and stepping up our standard microbial treatment. We assume that when we do not see a fungal element on microscopy, or we have clinical grounds to believe that this is not a fungal ulcer, obviously we do a microbial workup and we do cultures as well. And these are the colonies that we grow, and maybe we can again gram stain it, and my professor microbiologist has already said that we can go ahead and identify the species and start them on treatment. But if the species are fungal, we know that we always suspect a fungal keratitis. Then obviously the filamentary fungi is one that is very commonly seen. And if it's Candida, then we obviously switch over to amphotericin B in synergy with netamycin and voriconazole. So this is a basic treatment that a doctor would know, a general ophthalmologist would know, or anybody would know. So what to do if it's a bacterial or if it's a fungal. So what happens when you are practicing and you are referred a patient, when you're a corneal surgeon or you are in an institute and in the cornea department, what happens when these patients, they come with mixed kind of a therapy or mixed kind of an infection, and they've been treated indiscriminately with all kinds of antimicrobials and combination therapies and steroids. That is where the challenge lies, and that is where we need to be very careful in our workup and how to go about it. We understand that there are bacterial and fungal ulcers which take the whole course, and usually most of the bacterial ulcers have been treated with antibiotics, with steroids, for various reasons, and that becomes very challenging because steroids, as we understand, the signs get even less, the symptoms are less, and that becomes a confusing part than how to treat it. So we always encourage people to refer these patients if it's an ulcer in only eye, if the patient is a child, if there's an impending actual perforation which is occurring, that is when the disease is getting chronic and the regular antimicrobial therapy is not going to work. So what do we do in such cases? Look very carefully. There could be some other inciting factor. There could be a foreign body. We can take cultures right in there. We can culture the foreign body, which will give us some idea that why this ulcer is not healing. It could be so many other factors, and a lot of times it is the biopsy that helps. And my previous speakers have also told the types of biopsy that you can do. So it's usually an excisional biopsy when we have a LASIK flap which is already infected, infiltrated with Mycobacterium tuberculosis or any other microsporidia or any other post-LASIK infection, and that is when an excisional biopsy or an incisional or a lamellar keratectomy is also helpful in diagnosing and sending it to the histopathology or the microbiology lab for growth. And whenever you scrape these and you take a biopsy and you assume that there's a lot of thinning, that is when you should think that you should glue it, because not only it will help in maintaining the tectonic support to the cornea, but it also the tissue glue is also considered to be bacterio and fungi static. So my previous speaker also talked about intrastromal antimicrobial injections, which are very effective and almost the most effective in first-line intrastromal antifungal therapy. And the voriconazole drug is one drug which is available, and an immense publications are available online where you can actually go and do an intrastromal antifungal voriconazole injections. So this helps in direct drug delivery to the region and also provides a slow release of these antimicrobial agents. And thus, since we all know that fungus, it's very difficult because they are fungi static and very difficult to penetrate the intact epithelium at some places where you have satellite lesions or immune ring. That is when we scrape these, and debridement is the only treatment which is available. So it helps, these intrastromal injections help and also reduce the epithelial toxicity. Also, intracameral injections, like Dr. Fasika said, that intracameral amphoby and voriconazole is very extensively used in fungal keratitis, because we usually find these fungal keratitis which have lots of endothelial exudates, a big chamber which is full of exudates and fungus. We know they penetrate and they may go up to the iris and behind the iris and into the lens and beyond. That is when these intracameral injections, they help. So we do a proper AC wash with an intracameral injection of antibiotics, most commonly the ciprofloxacin group of antibiotics like amoxifloxacin, and intracameral amphoby when we are thinking of a candida infection, or intracameral voriconazole when we are thinking of a filament keratitis. So, but they carry a risk, and we should always be very careful when we are doing it, because it kind of breaches the natural barriers, and the infection may spread through the area that you have entered and may carry the infection inside if it was not so much inside. And obviously the risk of damaging the lens, having a glaucoma, a hyphema, and a potential endothelial damage is what we think of. Collagen cross-linking is another modality that people have tried, and this has worked the best with bacteria. Still, there are lots of studies which are going on for Candida, Fusarium, and Aspergillus, because it's not so helpful in fungi. That is what we have seen. But Staph, Staphylo, and Pseudomonas are three bacteria which get very they get killed because it acts on the DNA and RNA of the microorganism, and it kills the oxidation process, and the ultraviolet irradiation itself has a sporicidal and virucidal effects. So this is something that has been tried, and if we have a lack of tissue and we see it's a bacterial ulcer and it is fastly progressing, that is when we should think of doing a collagen cross-linking, though it adds an added procedure, but definitely it does work when nothing works too much. The another modality that people have tried is a bipedical conjunctival flap with an amniotic membrane, which could be cryopreserved and living related. This is mostly seen when we have a PED and an infection which is not healing because of drug toxicity. We are putting too many drugs, or something that we feel that there's a lot of necrotic tissue around and dead tissue around, and it is not letting the ulcer heal, is when then we can also think of putting a conjunctival flap, and this will cause the blood vessels to come into the area, and also the amniotic membrane, the basement membrane will act as a nutritional membrane, and it will help in healing. But we have to be very careful because the amniotic membrane itself may get infected and may lead to spread of the ulcer because of in the surrounding area. So these are cases which are localized, which are getting deep. We can do a double amniotic membrane or multi-layered amniotic membrane in these cases, and especially done in non-viral infectious keratitis, which are resistant to medical treatment, or PEDs, which are not getting healed by any other means. When we talk of some smaller perforations, what we are looking at here is getting a chance to heal these perforations in some way or the other, so that we avoid a keratoplasty. Because keratoplasty inherently is a very destructive procedure sometimes, and it may lead to phthisis if not done at the right stage. So we almost tend to save the globe by putting some kind of a glue or a cyanoacrylate glue, which works best. So we usually scrape these areas. We try and push the iris back if it's an early perforation, and also we can glue these areas, maintain the anterior chamber, and put a bandage contact lens. We can also do a tap when we are taking a patient for doing a surgery, because if we see a lot of as you can see, there's a lot of pupillary exudation that we see, and not too much of an exudation on the cornea. This is when we can do a tap. We can collect this and send it for surgery, send it for microbiological examination. So what other things that the research shows is that tarsography is something that we should not miss doing when we have persistent epithelial defects with persistent breaking down of epithelial membrane. That is when, usually in cases of PEDs or chronic ulcers or Murans, as the first speaker said, and also in cases where we are thinking that there's a graft there and there's a chance that the graft, the ocular surface is poor, or the patient has a dry eye. That is when we consider tarsography along with doing any kind of a procedure. And when you take the patient to the operation room for scrapings, you might as well do a tarsography in these cases, which would let the healing, promote healing, and infection would be under control by closing the leads and helping the patient. But in the end, when we come to the end of anything, what we see is that when nothing helps, then it's the keratoplasty that we see. And in India, we are lucky that we have eye banks in every city and every state, and we have these cases tackled very soon as we get these patients in our OR, and some of them could be as bad as this one with a pan off, and you may do vitrectomy, and later on a core vitrectomy and intraocular antibiotic or any antifungal, and put a graft. A lot of patients require these kinds of procedures, and it is better that we do an early therapeutic keratoplasty before the spread of any kind of infection, which may hamper the process. Here you can see there's a too much of exudation that we see here, and there's always a chance for an expulsive. That we prepare the patient preoperatively and see how it clears. And some of these patients do so well that most of the exudation is in the anterior chamber and it has not gone behind, and that is when by doing a proper scanning of the posterior chamber, B scan would help, and it would lead to saving the eye and ultimately leading to a better surgery. We always ensure that all these patients that we take for grafting, we send the tissue both for microbiological workup and also for histopathology, because sometimes the microbiology may miss something or may not show the actual process. But a lot of times the histopathology tells you the exact cause of the perforation or exact cause of the microbial keratitis, or whether it was viral and we need to add antiviral prophylactic medication to these as well because of seeing the viral features in the histopathology specimen. So it is very important to send these half corneal buttons to micro and half to pathology to get a clear idea on how we should go about it in future in maintaining the graft clarity and starting the treatment prophylactically. So in the end, I would like to say that the bacterial and the fungal ulcers, when we see the most in our clinics, and a lot of them require tissue glue. Almost 1/4 of these patients, they require a tissue glue and they heal on tissue glue. A third require a keratoplasty, and a 4% to 5% patients may require evisceration also, depending on the stage at which they present. But the situation becomes worse when we have bacterial and fungal in combination, and that is when the glue BCL doesn't work usually, and because you put a glue, you put a bandage lens, the penetration becomes less, and they end up with the keratoplasties more often than or than the normal cases, and also they have a higher chances of evisceration later during the course of treatment. Thus, the comprehensive review of corneal ulcer investigations and treatment modalities, that underscores the significance of timely and appropriate intervention. And we should be well aware of how we should go about it, and probably refer the patient as soon as possible to a higher center if it's not possible to treat. Thank you so much.
Thank you, Prof. I'm just checking on our chat if there's any questions for you. So there's one about corneal biopsies, but I think you've answered how you do the corneal biopsies. I don't know if you want to elaborate on that. And the other question is that this person uses a 2 or 3 millimeter skin punch at the slit lamp or in theater, using a crescent rate to dissect if during the procedure in theater and overlapping. Oh, was this you? Oh, this is
absolutely. I think any kind of biopsy in these scenarios is really helpful, and skin punch is a smaller punch, so you can just punch it, and probably that's the best way of taking a very decent clean cut biopsy, and it really helps. So probably that's a great idea to do a skin punch.
Okay, thank you. And then I just wanted to ask, there was a study that was published in a Swiss journal in 2022, which looked at using I think it was 0.66% povidone iodine in patients who present clinically with what looks like bacterial ulcers in the first 24 to 48 hours while awaiting culture results. And they showed that in patients who eventually had gram-positive infected keratitis, that there was quite an improvement with that mixture. Those that had fungal keratitis didn't worsen, but those that had gram-negative ulcers, they seem to worsen a bit. So with Dr. Mzmela telling us about antimicrobial resistance, and in trying to avoid that, would you advise or do you have any thoughts on using providing iodine instead of the broad spectrum empirical fortified antibiotics that we do use while awaiting the culture result?
So I would say that, see, Septidine or Providone iodine 5% is what is used as eye drops. And these are all bacteriostatic. And they do not have a role much in the fungal and the viral treatment. And usually in India, what we do is we use them pre-operatively in certain cases, and the contact time we keep about 5 minutes and we wash them because they definitely are toxic also to the eye. So when nothing works, you may add it as an adjuvant, but replacing them with an antimicrobial therapy would not seem to be a great idea. Probably Dr. Fasika, you can also tell us more about if you have any experience. This is what we have because we do not use in a regular treatment course.
Yeah, we the same thing that you mentioned, Dr. Tamar. We usually don't use it primarily. I mean, sometimes in viral keratitis they talk about the 5% betadine, or but we don't use it primarily either.
Yeah.
Thank you. Oh, there is one more question from Dr. Majola. You can come up.
Hello, yes, hi, Prof. Toma and Prof. Boreta. I've got one question for you. I have had trouble accessing natamycin topical eye drops, and I've had to rely on voriconazole as an alternative. I've actually used it subconjunctivally, and just simply because I thought it was less invasive. But I see you spoke about intracameral and intrastromal. I don't know, do you find that subconjunctivally might be less effective? And maybe I should start considering intracameral or intrastromal? What are your thoughts? And I mean, what is the reasoning? Because I've had quite good results, success with fungal ulcers.
So hi, Majula. Nice
Yes,
seeing you here. Yeah, Dr. Fasika, you can answer that.
And is that in conjunction with topical? Because I feel, I mean, subconjunctival, some people do, but if you think about the depth of the infiltrate, I think definitely topical voriconazole in addition to either, you know, subconjunctival or intrastromal. I mean, if you think about the intrastromal as well and the intracameral, it doesn't last long. So again, we usually do this in cases that are impending a therapeutic PKP, and you know the literature is sort of controversial on the efficacy of the intrastromal, but again we do this in sort of the very severe cases where if we don't try anything they're going to require a surgical intervention. So I think subconjunctival the same way that you'll do these in maybe more advanced cases if when the topical therapy fails as sort of again a last ditch effort.
I think I used it with oral voriconazole, just because, again, even the topical voriconazole was difficult to access.
Yeah. Well, yeah, I mean, I guess there's different, the topical, you can make the formulations, but for the oral vori, as I mentioned, whenever I hear oral vori, this was when I was a medical student and the cases steered in my mind of the death. So I always check the LFTs every 2 weeks, and I have seen patients where it increases the LFTs. You just see an uptrending pattern, and I stop it. I don't do more than 4 weeks duration of treatment because the efficacy, again, is not it. Again, from the MUD trial, it shows that the efficacy is, again, we don't have great evidence for the efficacy of oral. So if we do it, I think it should be limited, and remember the liver function test.
Oh, thank you. Thank you both of you.
Okay, let's check this Q&A for a question. So the question is, have you employed T-non-patch grafts in your practice for perforations? And if you can share your experience. This is from CJ in Australia.
Actually, Tenon's patch graft, they do work. Not that it's like raising a conjunctival flap. We do can have Tenon patch graft, but what we need to understand is there is an infection underlying, and whatever surgical procedure that you do may spread eventually if you are not on the right track, if you don't have the right culture sensitivity report in your hand. So all these things, they work, a Tenon's patch graft, or a conjunctival flap, or an amniotic membrane, or anything that provides a tectonic support would work. And Tenon patch grafts, and these, they bring in a lot of support and also vascularization to the area. But we need to be very careful when we are doing these kinds of surgeries, is when we do not see any underlying infection which can go down, and probably we have a perforation and we don't even realize that it's under the Tenon's wedge. So I'm like not a big fan of surgeries like these, but definitely you can do.
Okay, thank you. Are there any more questions? No, right. Thank you. I think that completes the question and answer segment.
I think we're going to try and get Dr. Zimela's video playing.
The whimsical world of diagnosing keratitis, where even the tiniest eye-related mishap can turn into a spectacle. In the pre-analytical phase, the whimsical
Sorry, guys, sorry. Unfortunately, we can't get the sound. Anyway, in closing, thank you so much to all our speakers, Dr. Balam, Dr. Mzimela, Professor Wright, and Professor Tomar. I think this webinar really just shows that we can't move away from multidisciplinary engagement in terms of the care that we provide, and especially from a teaching perspective, that we must understand we're always going to need each other as colleagues, and there should be more engagement that happens, as well as not just locally, but I think learning. We've learned so much today from different places, even though India and South Africa are similar in ways, but there's some interesting things that are different that we can learn from. So we really appreciate your time this afternoon. I'm sure the registrars are filled with information, and some of it new, and hopefully to help change practices. That is really the point, to enhance the knowledge and to change our practice. I really appreciate your time, and thank you so much. And hopefully soon we'll be able to engage with you again, and please take care.
Thank you so much, Dr. Mathe, for having us. And it was such a pleasure to be here and amongst you all, and seeing Majula also. So it's an icing on the cake. Thank you.
Thank you so much.
Thank you. Take care.
We'll be in touch.
Bye-bye.
Bye.
Bye-bye,
Thank you
Dr.
to all our
Pasika.
attendees who joined us virtually.